Welcome all delegates and thank you for joining this session. Today we are having a discussion on international speaker program on hyperuricemia and CKD to treat or not to treat. And it's a great honor to introduce Dr. Umesh Khanna, a senior and a highly respected, next slide. Next, yes, thank you. So it's an immense pleasure to introduce Dr. Umesh Khanna, a senior and a highly respected nephrologist with over 35 years of exclusive experience in nephrology, currently as a director of Kidney Associate and Lanceolate Nephrology and Dialysis Center, and honorary consultant nephrologist in leading tertiary care hospital. Dr. Khanna has extensive expertise in CKD, hypertension, hyperuricemia, dialysis, and renal transplantation, pioneer in establishing freestanding satellite dialysis centers in India with more than 16 units across Mumbai, and has made a significant contribution through research, publication, and national leadership in nephrology. It's a great honor to have him as a moderator for today's session. And for our panel discussion, our panelists, which are there, Dr. Majumdar. It's a pleasure to introduce Dr. Majumdar, Senior Consultant and Advisor in Nephrology at Manipal Hospital, Kolkata, currently as a President of Kolkata Nephrology Forum and a former President of the Indian Society of Nephrology East Zone with extensive leadership experience in academic and clinical nephrology. Our second panelist, Dr. Vinay Malhotra, Senior Professor of Nephrology at Super Speciality Hospital, SMS Medical College, Jaipur. He has served in multiple leadership roles, including Medical Superintendent and Additional Principal, and is a respected examiner and author of numerous national and international publications. And our third, but not the least, joining us, panelist Dr. Girish N.S., Head HOD of Nephrology and Transplant Medicine at Sparsh Hospital, Bangalore, a UK-trained nephrologist over 12 years of consultant experience, led India's first hospital swap kidney transplant, and has contributed to the India's first vascular access guideline, that is AVTAR. So welcome and thank you for joining today's session. Over to you, Dr. Umesh Khanna, for the introduction of Dr. Johnson.
Thank you so much, Ajanta, for organizing such a wonderful CME on a very interesting and important topic of hyperuricemia and CKD, to treat or not to treat. And we have a great speaker, Dr. Richard Johnson, who is Emeritus Professor of Nephrology from University of Colorado. He's an excellent clinician and scientist and has had a long-standing interest in research in uric acid. A prolific scientist with more than 850 peer-reviewed publications and is highly cited with over more than 100,000 citations. One of the founding editor of comprehensive clinical nephrology textbook, widely used in our field and widely read by many of us. So it is an honor and a pleasure to welcome Dr. Richard Johnson to give us his views on hyperuricemia and CKD, to treat or not to treat. Welcome, Dr. Richard Johnson.
Thank you. Thank you very much for the introduction. And I'm sorry we're having a very severe storm working well. So I'm going to be talking. I hope you can hear me, but I know you can't see me. So we're going to talk about hyperuricemia in chronic kidney disease. And let's go to the case, slide 2. The case is a 45-year-old woman.
I think the slides are not possible.
I'm sorry, what?
Yeah,
Sir, just a second. The slides are being displayed.
Yeah.
Please exit and then once again, please exit the entire this thing, slides. Yeah.
Tell me when the slides are up.
Sure, sir. Yeah.
Yeah, we'll let you know.
Yes, sir. The slides are up.
Yeah.
Okay. Slide 2 shows a case in which there's a 45-year-old woman with chronic kidney disease, gout, and hypertension who is on allopurinol, but her gout is not controlled and her uric acid remains at 14 milligrams per deciliter with a falling GFR. She has tophi and x-ray and other evidence for chronic kidney disease and gout. Next slide. The question is what to do next. And this patient was initiated on febuxostat therapy due to an inadequate response to allopurinol. She was given blood pressure medicine and lifestyle changes to go on a low purine diet, low sugar diet, and adequate hydration. So we're going to talk about chronic kidney disease and gout and hyperuricemia and the controversies around this condition. Next slide. So we know that uric acid is generated in the body in response to certain foods, and alcohol and purines are well known, but I just want to remind everyone that one of the major drivers of uric acid is sugar, and table sugar, which contains fructose, raises uric acid, and sugar is now known to have a major role in diabetes and gout, and it is very important in India because sugar intake has been increasing as sugar production has as well. Next slide, which would be slide 5. Now, uric acid levels will therefore vary among the population related to diet and genetics. And we define hyperuricemia as a serum uric acid of 7, or some people use 6.8 milligrams per deciliter. And when you use this criteria, approximately 20% of the population have hyperuricemia. And these people are especially at risk for developing gout. Now, next slide, please. Well, the important thing to realize is that gout is not just associated with, or high uric acid is not just associated with gout, but high uric acid is also associated with increasing prevalence of hypertension and increasing chronic kidney disease, increasing prevalence of chronic kidney disease. And quite a large percentage of people with high uric acid have chronic kidney disease. Next slide. Whereas in the normal healthy population without kidney disease, approximately 1 in 34 people have gout, maybe 3% of adults. In patients with chronic kidney disease, it is common for 25 to 40% of people with chronic kidney disease to have gout, as you can see in this slide. And even a higher percentage have hyperuricemia, close to 50 or 60%. Next slide. In India, the prevalence of gout in chronic kidney disease is 38%, and the majority of them are in males. So this leads to a big question that has been challenging everybody, and that is whether or not the high uric acid in patients with chronic kidney disease may contribute to more than just gout, but may actually have a role in causing kidney disease. We know that with kidney disease, there's decreased excretion of uric acid, so uric acid accumulates and there's high uric acid with chronic kidney disease. That is well known. But the question is, could the high uric acid in turn cause kidney disease? Next slide, please. And if it does, we first have to ask the question, how would uric acid cause kidney disease? And one of the main hypotheses is that uric acid crystallizes not just in the joints, but in other organs such as the kidneys, where it may cause kidney disease. Now, one big breakthrough, next slide, please. One big breakthrough was the discovery that gout, the crystals of gout can be seen by a dual energy CT scan. And when you use this special type of X-ray, you can actually identify uric acid crystals, shown here as these green crystals in the joints of a patient with gout. And we know that crystals are pro-inflammatory. They activate inflammasomes in white cells and other cell types that can induce an inflammatory response, releasing interleukin-1 and other inflammatory cytokines. So when they discovered that they could image urate crystals by the DEX scan, the dual energy CT scan, next slide please, they discovered that urate crystals can also deposit in blood vessels. And this was a big surprise, the idea that uric acid crystals might not just be in joints, but could be in other sites. Next slide. This slide shows that a DEX scan of a patient where the DEX scan is of the heart, and you can see calcifications in the left anterior descending in the coronary arteries on the left image, and on the right image we have a DEX scan showing that there are urate crystals that co-localize with the calcifications in the coronary artery. And this study, which was published in JAMA Cardiology, included, a number of imaging studies, but also they looked at it through autopsies and documented that where there were urate crystals by DEX scan, they could actually show them in the coronary arteries at autopsy. So these are real urate crystals that are depositing in the coronary arteries of a patient with gout. And that isn't very good, because these urate crystals are known to be pro-inflammatory. So it raises the question that they might be playing a role in coronary artery disease. Next slide. In that JAMA paper, Clauser, the primary author, looked at 59 patients with gout and found urate crystals in either the coronaries or aorta in 86%. And in a hyperuricemic control group, they found the crystals in 15%. So people with high uric acid, even if they don't have gout, may have urate crystals in their blood vessels, where it localizes to atherosclerotic plaque. Next slide, please. This slide should be labeled uric acid and atherosclerotic plaque. Okay. So in this slide, a study was done where they did carotid endarterectomies, and they removed the carotid endarterectomy, and they found that it was filled with urate crystals, and uric acid that the uric acid content was high in the atherosclerotic plaque. So what I'm telling you is that gout isn't just a disease of joints. Gout is associated with crystal deposits in the coronary arteries in a significant percentage of patients. What does this mean? Next slide, please. The title is Carotid Endarterectomy Samples Express Xanthine Oxidase. And again, they took these carotid samples and they showed that not only is uric acid present, but xanthine oxidase, the enzyme that makes uric acid, is also elevated in the atherosclerotic plaque. So not only are uric crystals depositing in the coronaries, but uric acid is being generated in the coronaries. So we've always known that gout was sort of a systemic disease because it's pro-inflammatory, can cause fevers and systemic inflammation. But now we know that it isn't just a joint disease, that these crystals can be in other parts of the body. Next slide. So Clauser did a repeat study where she looked at the presence of these urate crystals in the coronaries and looked to see if they could predict cardiovascular events. And if you have urate deposits, you have twice the risk for developing heart disease as if you have atherosclerosis where there's no urate deposits seen. So there is a correlation. If you have these deposits, you're at risk for heart disease. And next slide, please. This slide is labeled, Gout is associated with increased cardiovascular mortality. And here on the left, you have patients with normal uric acid, high uric acid, or gout. And notice that as you get to gout, there's a dramatic increase in overall mortality and cardiovascular mortality. But notice that there's also an increased risk if you're hyperuricemic. On the right side of the slide, you see a Mendelian randomization study. This is a study where they measure the genes in a person and look at the genes that are associated with high uric acid. And people with a high percentage of genes that raise uric acid have a higher risk for cardiovascular mortality and death. And there have been 4 or 5 more positive Mendelian studies involving heart disease. So whereas some of the Mendelian randomization studies have been negative for uric acid, at least for heart disease, they are positive. Next slide. So I'm going to tell you that gout probably does cause heart disease. And it's not surprising that having gout is one of the highest risk factors for cardiovascular mortality. It's not in the Framingham scale, but it probably should have been. Okay, so let's go on to gout and kidney disease. Well, we know that uric acid crystals form in the urine. We see that in our patients. They get uric acid kidney stones. But what we're learning, and there are many papers now coming out on it, and some that are under review in big journals, that show that if you have crystalluria with uric acid, that even though you may not have stones, the crystals are binding to the tubular lining and causing inflammation of the tubules. And this can happen when the uric acid is high and when the urine pH is low. And now we have evidence that both the high serum uric acid and a low urine pH increase the risk for kidney disease. And one of the thoughts is that crystalluria may be a cause of kidney disease. And keep your eye on the literature. There are some big papers coming on this. Next slide. This slide is labeled gouty nephropathy, urate crystals causing kidney inflammation. Well, the days before gout was treated, in the days before there was medication for gout, renal disease was the most common cause of death. And at autopsy in patients with gout, crystals could be found in the renal medulla of 90% of cases. However, if you do a kidney biopsy on a patient with gout, you may not see crystals because you're biopsying the cortex, not the medulla. And the crystals are associated with inflammation and fibrosis and with reduced GFR. And so this has raised the question that urate crystals in the kidney might be another mechanism for causing kidney disease. And some people believe that what happens is crystalluria causes inflammation of the tubule that leads to rupture, and then the crystals get into the interstitium. This is one of the thoughts. Next slide, please. But what about if there are no crystals? So this slide says hyperuricemia in the absence of crystals may also be pro-inflammatory. And you can see in the next slide, studies from our group show that uric acid, actually on the left side is oxidants. And if you put uric acid on cells on the upper left panel, it causes a fluorescence from oxidative stress. And on the bottom are the controls, and there's no fluorescence, so there's no oxidant production. On the right, if you have a look at nitric oxide, and you put uric acid on cells, you will actually block nitric oxide production compared to control. So I'm sorry, this slide's a little confusing. On the right, we show that uric acid stimulates inflammation and the local renin-angiotensin system. Basically, soluble uric acid is pro-inflammatory. Next slide. So now we have potential mechanisms by which uric acid might cause kidney disease and heart disease. So is there clinical evidence? Does treatment benefit patients? And their treatment options, next slide, it says treatment options. The treatment options include xanthine oxidase inhibitors that block production, uricosurics that facilitate urinary excretion. And you know these would not be good, right? Because as kidney function fails, these work less well, and we don't really want uric acid crystals in the urine. And uricases are work, but they're quite complicated because they have to be given by injection, and there are lots of issues with them. So it turns out that the best approach is with xanthine oxidase inhibitors. Next slide, please. And there are two major xanthine oxidase inhibitors available, and both are good. But they have different factors favoring them and so forth. So allopurinol is the classic one. It's less expensive, but it has some issues, especially for the India population, the South Asian. And that is, it can cause a severe hypersensitivity syndrome in which there's exfoliative rash, and it can be fatal. And one of the things that have been discovered is that it's highly associated with an HLA type called B58. And in South Asia, approximately 7% of people have that HLA type. It's much less in the US, where it's like 1%. It's much less in most populations, but in the South Asian, it's the highest of all groups, along with the Han Chinese. And so I think it's a little dicey to use allopurinol because there's an increased risk in your group unless you test for that. It also requires a dose adjustment in renal disease. It is retained in renal disease, and so often people give low doses, and we're afraid to give high doses. But as a result, often it's hard to control the uric acid. In contrast, febuxostat is a very effective xanthine oxidase inhibitor. It's a little more potent. It does not require dose adjustment, and hypersensitivity syndrome is extremely rare. So there's a lot of good things about febuxostat. So when the initial studies were done with allopurinol, and febuxostat, there were a lot of positive studies showing that if you started allopurinol, this is the next slide, it's called lowering uric acid with allopurinol slows renal progression in hyperuricemic individuals. And you can see in this study that was published around 20 years ago that there was really a nice benefit of allopurinol on slowing the progression of chronic kidney disease. Next slide. This slide is titled Febuxostat Improves Chronic Kidney Disease, a double-blind randomized controlled trial from India. And this was another early study. It was published only about 100 patients. But you can see on the upper panel, febuxostat was able to lower uric acid quite effectively. And actually, kidney function on the bottom panel, the kidney function actually improved from 31 GFR to 35, whereas the placebo continued to progress. So these kinds of studies were very, very promising and suggestive that xanthine oxidase inhibitors are beneficial. And in fact, multiple studies have suggested this benefit. And in this particular meta-analysis, where they looked at 16 studies and 12 randomized controlled trials, the 12 randomized controlled trials actually showed that febuxostat could improve GFR. Again, this is kind of, surprising because usually we try to block the progression of kidney disease. And here we're actually not just blocking progression, we're actually increasing kidney function. Next slide. There's also some studies showing that febuxostat, when it's compared to allopurinol, might actually be associated with lower all-cause mortality, fewer hospitalizations, and reduced hospitalizations for heart failure. And so, there's some clear studies that suggest that febuxostat may have some advantages over allopurinol. But I will say that most of this relates to controlling the uric acid. So if you can control the uric acid adequately with allopurinol, that probably would work just as well. But here's an example, another one in heart failure, where febuxostat actually not only does it have effects on kidney function, but it can improve ventricular function. And actually in this study, it did it a little better than allopurinol. So there are studies suggesting that xanthine oxidase inhibitors can improve not just kidney disease, but heart disease in patients with chronic kidney disease. And there's this next slide is febuxostat improves insulin resistance in patients with gout. And another benefit, and this has been seen with both febuxostat and allopurinol, is that you can improve insulin resistance a little bit. It's not huge, but you can improve insulin resistance by lowering uric acid. And okay, now we're going to go to the next slide. But then a question came up about febuxostat from the standpoint of its safety. And this was based on a study called the CARES trial that was published in the New England Journal. And next slide. And it says, is febuxostat safe? The CARES study. In this study, patients were followed on febuxostat or allopurinol for about 3 years. And what was surprising was the composite cardiovascular event rate was similar. And by the way, there was no placebo group, so we can't tell if these were better than placebo. But there was a lower cardiovascular death rate and total mortality in the allopurinol group. And this could not really easily be explained. And so it led the Federal Drug Administration, the FDA in the US, to give a black box warning for febuxostat, saying it might not be as best safe in patients with heart disease. Next slide. But subsequent studies, and this slide is entitled Outcomes from the FAST trial. Actually, there are quite a few studies that came out afterwards that showed that actually febuxostat is not inferior to allopurinol in terms of cardiovascular events. And in the FAST trial, there were fewer cardiovascular events in the febuxostat group. So, the way I look at it is I think that one study, it was a statistical issue. And it is certainly the repeat studies suggest febuxostat is safe. Next slide. Okay, so we were kind of headed towards the conclusion that lowering uric acid is beneficial in patients with chronic kidney disease because it can reduce cardiovascular events and kidney progression. But then came 3 large negative trials. And the slide is called, What About the Large Negative Trials? And next slide. So these 3 large clinical trials using allopurinol in patients with chronic kidney disease and heart disease were negative. And there was 2 were published in the New England Journal and 1 was in the Lancet. And you can see here, the first 2 studies were in chronic kidney disease, no benefits on outcomes. And the 3rd study was in heart disease. It was called the All Heart Trial. And again, no benefit. And so suddenly the world changes and we look at these larger studies and say, we were tricked by these small pilot studies and allopurinol or lowering uric acid is not beneficial. Now, I'm here because I believe that these 3 studies had problems. And even though they were big and double blind, I think that there were some major issues. So let's go to the next slide and talk about the reasons why these clinical trials failed. Next slide. So the first thing is that when you treat a patient with gout or a patient with hyperuricemia, you need to treat to target. And the target is to get the uric acid less than 6. And this Fernando Perez Ruiz, who runs a huge gout clinic in Spain, did a study where he gave allopurinol to all of his patients, and those who were able to reduce their uric acid to less than 6 showed a very significant benefit. So there was the total cardiovascular event rate, the mortality, total mortality was all much lower if you could get the uric acid levels less than 6. So it isn't about treating a patient. It's about treating a patient to target. If you start a medication on a patient, you have to follow the uric acid levels. And this is why one of the reasons allopurinol fails is because it's often difficult to control the uric acid in a patient with chronic kidney disease with allopurinol. Next slide. Now the dose matters because that's how you get the uric acid to less than 6. So like in this slide here, you can see that if you can get the higher the dose really translates into the lower the uric acid. And you can see that, that there's a dose effect. That's really the need to get the uric acid to target. Now the next slide, it says subjects should have hyperuricemia or gout. Yeah, this is another one. If you don't have hyperuricemia, lowering uric acid doesn't provide much benefit. So if you look on the left, if you look at the readmission for heart failure, if you have heart failure with gout, there's a much higher readmission rate. If you treat heart failure with allopurinol and there's no gout, there's no hyperuricemia, you don't get any benefit on readmission rates. But if you have someone with heart failure and gout, and then you treat them with allopurinol, you reduce the readmission rate. In other words, don't just treat heart disease with allopurinol, treat hyperuricemia or gout with heart disease. And this is one of the problems of those studies, by the way. Next slide. The next slide, the title says, duration is important. This really is important to point out that, if you have uric acid crystals, when you lower uric acid, you reduce the risk for recurrent gout, but it takes a long time for the crystals to dissolve. So if you control the uric acid, it can take a couple of years for crystals to start to dissolve, like tophi and so forth. And so here was a paper showing that allopurinol duration can actually reduce ventricular arrhythmias, kind of a cardiac outpoint, but it's totally linked with the duration. So if you do a 6-month study, you may not see an effect. You have to treat typically for 2 or 3 years. And all the most effective studies, are longer duration. Next slide. Adherence is key, is the title of this slide. And again, here's the point. If the patients don't take the medicines, they're not going to show a benefit. In fact, you have to be taking the medicine about 70% of the time. And if you do, 70% of the time, the percent reduction in cardiovascular events and kidney disease are much more likely to be seen. So you not only have to treat the target, you have to make sure people are adherent, and you have to treat for a long time. And here's the next slide. To show a benefit, the control group needs to have significant worsening of kidney function. And this is the FEATHER study, it was done in Japan, in which patients with chronic kidney disease were treated with febuxostat or placebo. And the study was negative, but I want to point out that the kidney function in the control group only decreased about 1 mil. That's hardly anything over a 3-year study. So basically, the kidney function stayed stable. So the only way you could show improvement is if the GFR improved, which, is, as we said, is relatively rare. But actually, next slide, please. In one subgroup, the group that had no proteinuria, the febuxostat group did show an improvement in GFR and a significant difference. So, I think the FEATHER study would have been much more positive if the patients had shown progressive kidney disease. But the fact that the control group didn't worsen explains why the FEATHER study was not so strongly positive. Next slide. So if we go back to these 3 large clinical trials of allopurinol in subjects with chronic kidney disease or heart disease, and that's the title of this slide, we suddenly look at it and we go, you know what? All 3 groups included patients with normal uric acid levels. Uric acid levels could be like 5 milligrams per deciliter. In fact, that was the mean in the heart study. None of them treated to target. All of them had a low adherence rate with high dropouts, and they all excluded patients with gout, which are probably the ones most at risk. So next slide, please. Now, I'm going to end my talk with this summary slide. So what did we learn today? What we learned is that gout and hyperuricemia is more than just a joint disease, that you can get uric acid crystals in the heart, in the coronaries, in the aorta, in the carotids, and they can cause inflammation, and it's probably playing a role in heart disease. We also have pretty good evidence that it has a role in kidney disease. And the negative studies failed because of some very important points. So first off, because of lack of adherence and high dropout and not treating to target. So here's what my conclusions. If you have a subject with gout and chronic kidney disease with a uric acid greater than 6.8, you should treat them. They should be treated with a xanthine oxidase inhibitor. I favor febuxostat in India, especially because of the high hypersensitivity rate, but either are good. Secondly, febuxostat has superior qualities in terms of dose adjustment. It does not cause Stevens-Johnson syndrome and is superior in meta-analyses. Probably because the target uric acid level was not hit as easily with allopurinol. And hydration and bicarbonate therapy may also be helpful to keep that urine on the alkaline side to reduce crystal formation. And then treatment is most effective if the patient is adherent, target levels are achieved, and if the duration of treatment is longer than 2 years. If you have a subject with asymptomatic hyperuricemia and chronic kidney disease, this remains controversial. But we know that some of them get crystals, 15%. We know that uric acid is pro-inflammatory. And we have a lot of pilot trials that suggest that lowering uric acid can be beneficial. And so I believe that it's certainly something we should consider. And when I see a patient who's on optimal therapy with marked hyperuricemia and renal progression, I like to consider them for treatment. But because it's not officially approved for such, I always discuss the pros and cons with the patient, make sure that they're on board, and we watch carefully for side effects and so forth. But I do treat asymptomatic hyperuricemia and chronic kidney disease when I see evidence of renal progression and when optimal therapy has not been, when they're on optimal therapy. And with that, I want to thank you for inviting me to speak. I'm so sorry about the audio-visual issues, but I hope you could hear me, and I'm happy to take questions.
Well, thank you, Dr. Johnson, for an excellent talk on a little bit controversial topic, but you made a very strong point about the uric acid being, or rather uric acid having a bidirectional relationship with CKD and even metabolic syndrome, and also made a strong point of not just kidney disease, but even heart disease and hypertension. It plays an important role. So unfortunately, most of the major guidelines like EULAR, KDIGO, AHA, ACC, even Indian Rheumatology Association do not give clear indication as to use it in asymptomatic hyperuricemia, which is the controversial part. So we have an eminent panel here. We would want to ask a few questions to them, and then maybe we could take questions from the floor. So Dr. Argya Majumdar, I think to take from what Dr. Johnson said, what is your way in which you treat hyperuricemia and CKD if it is more than 7, in which cases you opt for treatment in any CKD patient? I'm not just talking of asymptomatic. CKD patients with uric acid beyond 7, do you strongly believe that we should treat? What is your approach?
Thank you, Dr. Umesh. Now, definitely where the patient has gouty arthritis, there we are more proactive in starting treatment with urate-lowering agents at uric acid levels over 7. But so I don't think there is much doubt regarding that, because Dr. Johnson also showed the presence of crystals in the tubules, and there can be crystals in the blood vessels. So we are decreasing the interstitial nephritis as well as the vascular disease. Well, the debate and all the controversy is about asymptomatic hyperuricemia, where there is no gouty arthritis. But there, you see, the mechanistically, the evidence is quite strong. You know, the slowing of endothelial dysfunction, the inflammatory response, and also the because it does stimulate the RAS system and increase production of angiotensin 2. So it makes sense.
Yeah, the physiology is favoring us in.
Yes, physiology is favoring, but as he said that, the previous pilot studies definitely were encouraging. There was meta-analysis done with it that was encouraging on over 1 lakh patients. But then came these two major studies in 2020 in NEJM, the CKD fix in USA and the Pearl study in US
study.
and the CKD fix in Australia, New Zealand, which showed no benefit from these therapies. But as Dr. Johnson has shown that there were some side effects, even going through the studies, I had noticed that, they have started at levels which are very low, even 6 and 5, and they are not treated to target. So maybe, we have to relook at this. And I think as in our Indian guidelines as well, we have suggested that over 9, definitely in CKD stage 3 and higher, if there is rapid progression, and if the levels are over 9, definitely we should start thinking about.
Are you talking about the IDEA consensus? Because Indian guidelines.
The Indian Society of Nephrology guidelines regarding hyperuricemia.
Beyond 9.
Yeah.
So we'll go back to Girish as to his approach. But I think most of the East Asian guidelines, actually the Japanese and Chinese guidelines are a little more tilted towards treating, while the EULAR, KDIGO, AHA, ACC are giving the guidance of not treating. Girish, what is your opinion? And then if you treat, how do you start, whether allopurinol or febuxostat, and how do you titrate?
Thank you for the question, sir. So basically, with my training and practice in the UK, I was sort of biased towards not treating asymptomatic uricemias. Like in the NICE guidelines, we don't tend to treat asymptomatic hyperuricemias at all, unless there is evidence of progression of CKD or recurrent gout attacks, tophaceous gout, etc. So, but however, as the evidence has mounted in favor of treatment, even though there are some observational meta-analysis data, it's still a subject of controversy. The fact that since I've started practicing in the UK, in India, for the last 10 years, I've noticed that we as an Asian population differ to the Westerners. So we have to probably incline more and take lessons from the Japanese and the Chinese guidelines, which is more suited for our population. Which is where I agree with the ISN position statement, where they say that if the uric acid is more than 9, we should treat it. And I think that's probably is my practice. It is something similar to hyperphosphatemia in CKD patients as well. We know that lowering probably reduces mortality, but it's not proven beyond doubt by RCTs. So and now the way we are managing all the diabetes, heart failure, and the metabolic syndrome is more like a pillared approach. You're sort of using all the drugs at the same time to get the benefit rather than using stepwise. So I think somewhere hyperuricemia is also sticking out as a small pillar to start with. Maybe as we progress, we may actually add this into the treatment of the metabolic syndrome milieu.
Right.
That is my personal.
Yeah. So Vinay, allopurinol or febuxostat? All of us have burnt our fingers sometime in our life when we saw allopurinol causing the Steven Johnson kind of picture. What is your approach? Do you start with allopurinol or febuxostat, and how do you titrate it?
Right. As you have rightly mentioned, the hypersensitivity reaction with the allopurinol and the HLA-B58, so very common in our part of country. So these patients are more prone to the hypersensitivity reaction and other side effects also, the GI side effects. So I prefer febuxostat, start with the low dose and titrate it slowly. And the most important is treat to the target and adherence of the patient. These two things are very important. So we know the target that, So, sir, you have to unmute yourself, sir.
Yeah.
So you have to treat to the target and adherence of the patient and the duration also. So the long duration, yeah. So it should not be a short duration therapy. It's a long duration therapy.
So I think corollary to that, there was a question in the chat box as to when do you stop, or once the uric acid comes down below 6, what do you do?
So I think we can reduce the dose, but we have to continue. Yeah.
Yeah, I think what Dr. Johnson also mentioned, that the duration of therapy is an important way in which you will get the results from the treatment of hyperuricemia. I think maybe any of y'all can take this question. What about in transplant patients? Arya, you want to take this question? And are you scared of using febuxostat in transplant patients because of the issues of, say, azathioprine or say TAC levels or anything? Are you scared of using?
No, I think febuxostat has been shown to be quite safe in transplants. It doesn't affect the graft dysfunction and doesn't interact with any of the drugs like tacrolimus or mycophenolate.
Yeah, so it doesn't interact there, but only I think Azoran we try and avoid allopurinol.
Allopurinol with Azoran.
But I think a lot of us are a little worried of febuxostat also with azathioprine, but we are not worried of its usage with any
mycophenolate. Yeah, and it is effective.
It is. So do you want to take any questions, Ajanta Pharma? Are there questions on the, otherwise we'll ask, I think there were some questions. Let me see. Yeah. What's your lower limit target for uric acid, which you think about de-escalation and urate lowering drugs? I think we mentioned it should be below 6. If uric acid is high in CKD 5D, what is the best strategy to treat it? Girish, in CKD 5D, patients on dialysis, what do you do?
I think I would still follow the treat to target approach and try and keep the levels less than 6.
Yeah, especially I think allopurinol one would be more scared of using it, and a small dose of febuxostat would be enough.
And dialysis will also help in removing the
uric acid. I think there's one more question. How low should the target be, especially in CKD with neurodegenerative diseases? I suppose less than 6 is what we use it in any other treatment for hyperuricemia. I think there was an important point. What is this? Choice of treatment of hyperuricemia in HFrEF.
Yeah.
I think it shouldn't
be. I don't think,
different in any way, except probably losartan would be a good drug to use if you're using ARBs because it has an additional quality of reducing uric acid. But otherwise, I think you may have to use febuxostat. Fortunately, I think in our country, febuxostat is easily available, reasonably priced, and most of us, I think, are using febuxostat over allopurinol. So we face less of the issues of it. Vinay Malhotra, would you want to do liver function test before starting or monitor it after some time, or you are okay?
I think we should monitor, yes. Routinely also we are monitoring in our patient. So for this also we should monitor. Yes.
Okay. And how long I think we have sorted? Indian guidelines, we have already said that we are more lenient in starting if the uric acid levels are beyond 9.